So we're delighted to have Dr. Scott Damrauer with us. He was with us, I think, 2 years ago, maybe, when we were in person last. And so he will speak to us about PXE and vascular disease, specifically peripheral artery disease. Take it away, Scott. Thank you.
Great. Thanks, Terry. I'm excited to be back. Yeah, I spoke 2 years ago in Philadelphia, which is actually where I live. I'm an assistant professor of surgery at the University of Philadelphia, and I'm a vascular surgeon. And so what I thought I would do today is talk about peripheral artery disease in PXE and really focus on a clinical message on what treatment opportunities there may be and what research opportunities there may be. These are my disclosures. I don't have any financial disclosures. What I thought I would do is actually start by talking about peripheral artery disease in general, and not necessarily peripheral artery disease in the setting of PXE, really to give you a background of how we think about it, how we treat it, and what the goals of that treatment are and what the outcomes are, because I think it's a nice framework to think about how we can approach it in the setting of PXE, because there are ultimately probably more similarities than differences with respect to what we have to offer for treatment. So peripheral artery disease is narrowing of the arteries in the extremities. And while it can occur in the arms, we really think of this as occurring in the arteries that go to the legs. And the thing that most people who have peripheral artery disease complain of, or at least much of the initial symptoms, is something we call claudication or intermittent claudication, really. This is pain when they walk. And so what happens is, because of the narrowing in the arteries, less blood can get to the metabolically active muscles of the legs. Now, when you're sitting around at your desk or on the couch, you don't need a lot of blood getting to your legs to keep those muscles going. But once you start walking, the metabolic demand increases, and given the restriction in blood flow, people start to have pain in their legs. If at that point they stop and rest, the pain goes away, and the symptoms tend to be very reproducible. And so people who have classic intermittent claudication really complain about being able to walk a certain number of distance, and everyone is actually very clear how far they can walk. So they can walk 2 blocks, they can walk a block, or they can get to the corner store and they have to stop and rest, and they can get the same distance a second time, and then they have to stop and rest. And this is how a lot of people come to presentation. Now, when you think more broadly about the spectrum of symptoms in peripheral artery disease, intermittent claudication is really only one set of symptoms. There's a majority of people who have no symptoms at all. And there's some people that have, and it's not shown here, atypical symptoms. And this actually tends to be more women than men. And this is just kind of atypical leg pain that doesn't fit the intermittent claudication paradigm, but is certainly ongoing leg pain that is due to their peripheral artery disease. On the other end of the spectrum, we have rest pain, which is pain not in the legs, but truthfully, it's usually in the feet, that occurs without any activity. This is when peripheral artery disease gets so bad that enough blood flow isn't getting to the extremities even at rest. And the reason it hurts the feet is they're just happen to be the farthest away from the heart. And what a lot of patients who have rest pain complain of is not being able to sleep through the night, because when they lie flat, their feet hurt, and they have to wake up in the middle of the night to dangle their feet off the side of the bed so that gravity can help the blood flow get to their feet. A lot of these people are sleeping in recliners, and really, it really impacts the quality of life. Even more severe is when the lack of blood flow gets to the point that you start developing ulcers or tissue loss on your feet. And to reflect the severity of these last two groups, we call that chronic limb-threatening ischemia, because when you get to this level of symptoms, what we really begin to think about is, what we can do to preserve your leg, because you're at risk for losing it. Now, in the setting of intermittent claudication, which again is how most people present, it's a very different picture. Of everyone with intermittent claudication, only at most 30% of them will ever even get worse than how they originally presented. And so somewhere between 10 and 20% of people have progressive claudication symptoms, but never really go beyond that. And only about 5 to 10% of people progress on to have chronic limb-threatening ischemia. What's actually more common, and this is again in the setting of traditional peripheral artery disease, is that 30% of the people go on to either have heart attacks, strokes, or cardiovascular death. And this is because the same lesions that form in the legs, in the arteries of the legs, also form in the arteries of the heart and in the arteries that go to the brain. And so when we think about treating PAD, what we really wish we had is something like this, a pill or an injection that if we gave you, it would dissolve all the blockages. And in many cases, if we had something that worked like this and it treated calcium-based blockages, it would work in PXE also. But unfortunately, for either disease, we don't really have this type of therapy. And so what we're left with is really 3 different approaches to treating it again. And this is regular PAD, but I think this is where you'll see as I continue to talk, I think things become similar between both diseases. And so the first is we want to prevent other forms of cardiovascular disease. And so this is risk factor modification. Among the biggest risk factors for traditional PAD include smoking, high cholesterol, and diabetes. And so we work on addressing those risk factors. Most people end up being on an aspirin, and we also recommend most people take a statin or a cholesterol medication to prevent progression of the disease. Now, that doesn't actually treat the thing that bothers people. What bothers people is the leg symptoms. And for the leg symptoms, there are really 3 main options that work in a graduated fashion. The first is supervised exercise therapy, which I'll talk about in a moment. The second is there's one medication that is FDA approved that has some efficacy, and that's called popliteal. This helps somewhere about half of the people increase how far they can walk by a third as far. It's not great overall. It does certainly help a small percentage of the people. And then many people can't tolerate it in general due to GI side effects. And then finally, when those approaches don't work, what we're left with is thinking about a revascularization to get more blood flow to the leg. In the setting of critical limb-threatening ischemia, we really focus on wound care and revascularization. These other approaches don't have a role. And so what is supervised exercise therapy? And it's worthwhile talking about in detail because I think it is a valuable therapeutic strategy in the setting of all vascular disease, whether it's due to traditional atherosclerotic disease or whether it's due to calcific disease in the setting of PXE. And so when we send people or we instruct people to do supervised exercise therapy, what we are talking about is repeated bouts of walking until they have pain, and then stopping and resting and starting it all over again. And the goal is to ultimately work up to being able to walk for 50 minutes per session and at least 3 sessions a week. And this usually takes about 3 months to build up for this. And that's usually the amount of time that we give people to see if it's working. All of the studies that have shown that this is really effective, and I'm going to show you, I think the best study, have done it in a supervised fashion. And that's going to physical therapy 3 days a week to work with someone who basically makes you walk. But there's certainly, for individuals who are motivated, can do it in a non-supervised fashion. And there's nothing special about the walking. It's interesting. You can do it depending, again, on where you live and what your setup is, either indoors or outdoors. Indoors, obviously, on a treadmill. Although what is interesting is when you test people, the people that walk outdoors tend to do better when you test them again by seeing how far they can walk outdoors. And the people that tend to walk indoors end up doing better when you give them a treadmill test rather than when you actually ask them to walk on a track or outdoors. But either way, it's very, very clear that this type of approach to targeted exercise improves how far you can walk in the setting of vascular disease. It doesn't improve the blood flow to the leg, but it really conditions the muscles to work with less blood flow and less oxygen. Now, in individuals who that's not enough, and again, this is another area where there's commonality with PXE, we start to think about operations or interventions to improve the blood flow. And this diagram shows the blood flow to the legs. You have the end of the aorta here, branches into the iliac arteries, and then branches into the femoral arteries going down the legs. And the diagram illustrates a number of different approaches. And so in the past decade or two, we've really moved towards a lot of endovascular approaches. These are therapies that we do with catheters and balloons and stents that don't require big incisions or really any incisions at all, and are usually done with mild sedation as an outpatient procedure with a one-night overnight stay in the hospital. And really what they involve is inflating a balloon either with a stent in it or a balloon without a stent, and then later putting a self-expanding stent across the blockage. When people talk about like a roto-rooter procedure or that kind of thing, that's really what they're describing. This was a technique that was first developed in the coronary arteries in the heart and is kind of the mainstay of how we treat coronary artery disease, and now has migrated to be used in the legs. There are many cases when a percutaneous intervention like these done with catheters isn't enough or is not the best way to treat the problem. And in those cases, we revert to doing a number of different operations that are kind of two general flavors. So the first is diagrammed here, which is an endarterectomy. So we make a small incision in the artery, we clean out whatever's blocking it, and we put a little patch on to make it a little bit bigger so that it's less likely that the disease comes back. On the other type of very traditional procedure we do is if you have a blockage here, we'll do a bypass using either the patient's own vein or a graft made usually of Gore-Tex, and just literally sew a tube from above the blockage to below the blockage. And these are very, very durable interventions that have been done for 40, 50 years with tons of follow-up, and we really understand how they work. And we really see them as the gold standard for revascularization. Now, the kind of advantage with the revascularization is that you get better right away. We immediately restore the blood flow, and it doesn't, other than needing to undergo an operation or a procedure, it doesn't require active ongoing work on the patient's part. Although that's a big downside, it requires an active, an operation or a procedure. And so people have looked at whether the comparison between how exercise versus having an operation procedure works, and trying to see if one is better than the other in the long term. And so what they did, and this is one example called the Clever trial, is they took individuals who had disease in their end of their aorta and the top of their iliac artery, so kind of in the lower abdomen that block the blood flow to the legs. And they randomized them either to receive just usual medical therapy plus supervised exercise, or revascularizations with stents. And what they saw was at 18 months, the outcomes with supervised exercise therapy were just as good or better than the outcomes from using stents. And so on one hand, while it requires extra work, it certainly gets you there just as well, if not better, than going and having an operation. And that's really why it comes in as supervised exercise therapy comes in as the first line therapy for peripheral artery disease. So now let's switch gears and talk about what we're really interested in, which is peripheral artery disease in the setting of PXE. And I think it'll be helpful to have the background I just shared with you. So it's been known for a long time that PXE results in vascular calcification. And so what do we mean by that? That's deposition of calcium, similar to the calcium in your bones, in the arteries, predominantly in the extremities. And so what I'm showing here are a number of pictures that are illustrating this from a few different publications. So this figure in the center is an X-ray of a knee taken from the side. And what you can see here running in the back in this white line that the black arrows are pointed to is calcium deposits in the popliteal artery. And so in the absence of calcium deposits, you don't see this artery at all in this type of image. The same thing is true here for this CAT scan of someone's legs. And so this is a picture from the front to the back using a CAT scan in which they've been given no IV contrast or anything to make the arteries light up. You can see the arteries here coming down and then branching in the lower legs because there's calcium deposits in them. And that's why the color of the arteries looks very similar to the color of the bones. Here you see a CAT scan section of a person's head. For reference, here are their eyes. The nose is up here, and this is kind of the sinuses. But right here are the carotid arteries, the internal carotid arteries, which are taking blood to the brain, and we shouldn't be able to see them at all. This white right here that looks like all of the other bones in the film is actually the outside of the arteries. And again, that's not something you normally see. Again, here, these are someone's arms folded over their abdomen on a CAT scan, and you can see the arteries taking blood flow to the hand, again, marked because they have the calcium. Now, this last thing I want to show you is a little bit different to think about. This is an MRI scan, and the white in this case is lit up because the patient has been given something to make their blood bright. And so unlike the previous pictures where we shouldn't see the arteries at all and we only see them because of the calcium, here the blood is bright and it allows us to see where the arteries are not, or where the blood is not flowing. And to make this easier to see, I've basically colored in red everywhere where there should be a white line, but there's not. And so you can see the groins are here, the knees are here. And what you can see is at multiple levels in the femoral arteries in the thigh, in the popliteal arteries behind the knee, and in the tibial arteries in the lower half of the leg, arteries are missing because there's no blood flow in them because they're completely blocked with calcium deposits. This was a study that was done in 103 patients with PXE, and they compared them to a group of 93 individuals who did not have PXE, and they looked at where calcium deposited in the arteries. And they essentially saw across the entire arterial system. So these are the arteries in the neck and head, the internal carotid arteries going to the brain and the vertebral arteries going to the brain, the arteries of the heart. We see calcium deposits, although at much lower rates, on the valves. But what's interesting is much of this is similar between people who had PXE and people who didn't have PXE. Where we see the real differences are in some of the arteries to the brains, the arteries to the arms, and then in the arteries to the leg. And this again is why claudication is kind of one of the symptoms people have when they have PXE. And so we see either in the arteries to the legs that are still up in the lower abdomen, the iliac arteries, or in the arteries to the legs above the knee or below the knee, significantly more and higher degrees of calcium deposition and narrowing in patients with PXE, which is the P column, than in people without. This is another study that essentially looked at the same thing and that found in albeit a smaller group of patients with PXE, that about 33% of them had either calcium deposits to the point that the arteries were narrowed or completely occluded. I think this is actually one of the best studies, and it just came out last year in the Journal of Clinical Medicine, looking at vascular disease in the setting of PXE. And they looked at 93 individuals. And one of the things they did is something called ankle brachial index testing. And this is a great screening test of how we as vascular surgeons think about diagnosing people for vascular disease. It's very, very easy. It's literally the blood pressure as measured in the arm and the blood pressure as measured in the leg. And you divide the blood pressure in the leg by the blood pressure in the arm. And the normal value is 0.9 to about 1.4. And what they found is in roughly 100 patients with PXE, the average was 0.92, which is significantly less than it would be in a patient without vascular disease. And 37% of them, about a third to half, had evidence of peripheral artery disease because that number was less than 0.9. And when they further had them exercise, what they saw is the average number dropped. And by the criteria we use when we measure this after exercise, up to 60% of them had peripheral artery disease by that definition. And so that's a pretty high proportion of people having measurable narrowings and blockages resulting in reduced blood flow to the legs in the group that they looked at. They then actually just asked them about the symptoms they had. And what was interesting is only about 23% of the individuals overall had symptoms of claudication, which is leg pain when you walk that improves with rest. So it's very clear that these calcium deposits are common and are causing symptoms in individuals. So the question becomes what to do about them. And this is where we really fall back to the same treatment strategies as traditional peripheral artery disease. When we think about this surgically, people have tried to do stenting to open up the arteries, but there really is not much experience or description in the literature of the outcomes. So there's about 2 case reports of people treating the aortoiliac segment of the vasculature. So this is the aorta, which is the artery that takes blood most places in your body. And we're talking about narrowing in the section that's somewhere around your belly button as it branches to the iliac arteries, taking blood from the belly button area to kind of the tops of the legs. So that's kind of thinking about where this is on someone. And so you can see in the left beforehand, this is an MRI and the blood is white, that the aorta comes down and then it kind of stops. There's a short segment narrowing here on the right before the blood flow picks up. And there's a much longer narrowing here on the left. The directions are reversed if you're not used to looking at these. What they did is they used balloons to cross this. They inflated the balloons and dilated the area and then put in 2 stents, again, done through basically nothing more than getting IVs in the groin. And we're able to open this up. Now, this is on arteriograms. The blood is black, but you can see the blood now, shows nicely through these 2 areas. And what these 2 reports showed is that when treating this portion of the vascular system, the results were technically good and they were robust. Now, granted, it's 2 people, so it's hard to know really what that means. And I think this advocates for the need for a lot more research, but not even research, just data gathering, simply knowing from registry data. And Sharon wanted me to plug both the PXE registry and the importance of contributing registry data, just simply from knowing what procedures things people have had done and how they've turned out, we could better understand whether or not this is a good way to treat other people that have this type of disease in the setting of PXE. The reason I say that is because when you start thinking about disease below the groin in the leg, endovascular approaches have very different outcomes. And so there was a series of cases reported in the Journal of Vascular Surgery back in 2015, in which they looked at interventions in 7 out of 8 limbs in 4 patients. So, right, if you think about this, 4 patients, they each have 2 legs, that's 8 legs, 7 of the legs had endovascular procedures done in them. And so what they did is they did stents essentially. And here's an example of one of them. This is the femoral artery. So to orient you, the groin is up here. This is the femur bone. And then the knee is right here. And so you can see black is the blood. And you can see this area right here denoted by the yellow arrow where the artery gets much narrower and a little stops for a second. And so what the surgeons did is they went in and they ballooned it and they put a stent in it. And when they were done, this is what it looks like. And that's, I got to tell you, that's like a perfect result. This type of procedure never looks better than that. And the patient felt better until the next day when the patient started complaining of their foot pain coming back, and they took them back to the angio suite. And this is what they saw. not only did they have that little blockage that was back, but the entire segment of the artery, so from here to here, which yesterday looked like this, was totally missing and had clotted off. Now, luckily, they were able to restore the flow and return it to look like this with some stents. And that worked in the long term. But what they saw is within about a year, that stopped working again. And ultimately, in all 7 cases, within about a year, these procedures stopped working and didn't give durable results in individuals with PXE. Now, we know that the durability of any of these interventions is limited. And when we do them in the setting of regular, bland atherosclerotic peripheral artery disease, they're not interventions that last decades, but we generally think of them as lasting longer than a year. And so I think this paper raises some questions about the durability and the technical success of these operations and procedures. I can think of a couple of technical reasons why, and one of them is that calcific artery disease is very hard to treat endovascularly, because what you're talking about is essentially calcium, which is a mineral deposit in the artery, which is hard. And so unlike atherosclerotic plaque, which can be soft and you can balloon open and then you can put a stent in to hold it open, you're really talking about now dealing with something that's like a little pebble or a rock. And so that's much harder to treat. What's interesting is in the past year or two, there's been a new modality that's come out that I think may offer some really intriguing opportunities for treating artery disease in general, but actually PXE vascular disease in particular. And that's shockwave lithotripsy. And so people have figured out how to use shockwave like we used to treat kidney stones to dissolve calcium deposits in the artery. And so if you look here, and this is not a PXE patient, this actually, a lot of patients with peripheral artery disease get calcific disease in their arteries, and in particular, patients with chronic kidney disease. So this is an individual, again, this is the knee. Their artery is coming down like this, black is blood. And you can see all of these areas where there kind of is no blood because of narrowing and blockages. And when you just take a regular X-ray without giving them the contrast material to make the blood black, you can see where these chunks of calcium are because they actually show up darker on the X-ray. And so what this technique involves is you put a balloon across the area and you inflate it so it touches all the calcium, and then you turn on this shockwave device and it essentially breaks up and dissolves all the calcium. And after the procedure, actually you're left with this, which is a very, very beautiful result. Now, aside from the main artery having reestablished flow, you can tell that there's really good flow through the main artery because beforehand you essentially saw all of these collaterals, and afterwards they've gone away. What this is these are kind of, you can think of them, if this is the expressway, these are all of the side streets that the blood is kind of getting off and taking the side streets to get down to where it wants. But now that you've restored the expressway, the blood's very happy just to stay on the expressway and end up where it's going. And so I think that when faced with patients who have more calcific disease, this really does offer us an opportunity to offer something that's been fundamentally different than we've offered in the past. So this type of approach may change the technical success or durability of lower extremity interventions in the setting of PXE, but no one's looked at that specifically. When peripheral interventions like this don't work, what we're left with is doing the traditional infrainguinal lower extremity bypass. And so as much as the previous paper that I showed you was not optimistic about the technical success or durability of these interventions when they were percutaneous, stenting, and ballooning, everyone who they did a bypass on had excellent long-term results, which I thought was very encouraging. Now, some of the bypasses can be rather complicated because having calcified arteries makes it hard to technically do the bypasses, but they're really, these bypasses were having durability and patency that really was the same as we see in individuals without PXE. So to me, that was encouraging that kind of our best and most traditional surgical approach, if it could be done, worked just as well. So what are the treatment challenges then to treat vascular disease in the setting of PXE? Well, I told you one of the key things we do is risk factor modification. We get people to stop smoking. We get them on cholesterol medications to lower their cholesterol. We treat their diabetes. None of these are causes of PXE. None of these will make necessarily, with the exception of perhaps statins, as you heard about, maybe an emerging therapy previously, are necessarily going to directly affect the PXE-related vascular disease. But I can tell you, having PXE-related vascular disease doesn't mean you can't also get regular peripheral artery disease. And so all of these other risk factors do need to be controlled, because you don't want to have to deal with both of these on top of each other. So it really still does make it important to make sure lipids are within target prevention guidelines, not be smoking, have diabetes very well controlled, weight management, be physically active. There are also challenges with respect to revascularization. As I've talked about endovascularly, and it's true for open surgery as well, dealing with calcified arteries is very challenging. One of the other challenges is, as some of the kind of survey data showed previously when they looked at where the calcifications were, the involvement of the very distal arteries is a common hallmark of PXE. And as you can imagine, if you're thinking about a bypass, it's one thing when you're bypassing the expressway, the artery in the thigh, or you're bypassing a main artery. But the farther and farther you get down in the leg, the less durable those bypasses are and the harder they are to do. And the chances that they work are significantly less. So I think there are still some significant challenges. But in terms of a treatment paradigm, aside from potential emerging therapies for PXE, I think we're left with really treating this the same as we treat atherosclerotic peripheral artery disease. And that's why I spent so much time talking about it. It's managing the medical risk factors that we can manage to try to not have to deal with atherosclerotic vascular disease on top of PXE-mediated vascular disease. No one has studied it, but I think that supervised exercise therapy there's no reason to think that would not work. That doesn't do anything special in atherosclerosis. It's really about conditioning the muscles to deal with less blood flow. And so I think that would be very clearly the first line therapy. Cilostazol, likewise, would almost certainly work, but I think one of the challenges with cilostazol is that, like I said, it just doesn't work for a lot of people and it's hard to tolerate. And then finally, revascularization for disabling claudication or CTLI, perhaps recognizing that endovascular approaches may have limitations and may not be as durable. That doesn't mean that we shouldn't, necessarily still try them first. I think it just means we have to calibrate our expectations. I think, unfortunately, the problem in knowing how to do these surgical procedures or what to do or what the outcomes are is we just don't have a lot of data. I mean, the surgical outcomes I presented you really was like 6 patients. No one has studied this in any numbers, and it makes it challenging. So what we don't know in my mind is what the true rate of PAD and claudication due to PXE are. A study of 100 people is not a big study. The beauty of this is this could be answered really just easily with registry data. There are validated surveys that people can take that give us, not perfect, but are pretty good as compared to ankle brachial index testing to diagnose peripheral artery disease. It's 5 questions. It's been around for 30 or more years. So a very easy way to look across the entire registry at what the rates in a large number of hundreds of people are. I think we don't know what the rate of vascular interventions is in individuals with PXE. Is it more than we see in typical patients with claudication, or is it less? And what the durability of those interventions are. The gold standard answer to this would be to review a ton of patient charts. But I think in an educated patient population, you can also get this with surveys. So again, registry questions asking about what procedures have had people done, how long have they lasted, have they had to have more than one procedure, gets you really, really far along the way. And then I think there's an opportunity to ask what the other vascular manifestations are. What is the rate of coronary artery disease? And this isn't going to be able to be known in 100 people. You're going to need, the entire size of the registry, because you have to compare it and say, okay, we expect as people are getting older that there's more coronary artery disease. Is it more than we would see in kind of a similar group of people in the population? What about artery disease? Someone asked about the arms. What about symptomatic artery disease in the arms? What about stroke due to cerebrovascular disease? So again, a lot of this is stuff that we could get at with questionnaire data. And with that, I'm actually gonna stop there, and I'm happy to answer any questions.
Great, thanks so much, Scott. That was fabulous. I hope you guys heard that if the 1,000 people who are registered in the registry answer, we do have the validated instruments, the questionnaires that have been used for decades, ready for you to answer. So we would find these answers out. And we also connect to 700,000 portals in the United States for EHRs. And so somebody like Scott could look across all of you in the US and abroad and see what we're actually seeing around PAD in people with PXE. So we have a couple questions. You caught one of them.
I saw
Scott.
those. Yeah. Do you want me just to go through the chat and kind of go at these one by one? So if we start with Rosalind's question, I don't know that we know for sure, specifically in the setting of PXE, what the right level to start a statin is. And I'm speaking of this from a cardiovascular standpoint, not from a statins may have a role in PXE treatment standpoint. But what I would say is that at a minimum, people should be treated according to primary prevention guidelines, recommending kind of the risk associated with treating a statin. And in fact, one may argue that you want to apply secondary prevention guidelines, which are lower levels of cholesterol to start a statin. So secondary prevention guidelines are, you've had a heart attack, you've had peripheral artery disease, you've had a stroke, you have diabetes, you have chronic kidney disease. We're trying to prevent a second atherosclerotic complication. There may be an argument, and again, no one knows, to even use those guidelines, because what you really want to do is be aggressive about preventing atherosclerotic vascular disease on top of calcific vascular disease. So that I'm sorry, Rosalind, that was kind of a non-answer to your question, but I think it's a framework to think about it on. And I think the important part is discussing this with your primary care physician. I don't have any advice on contraceptive use there. I think the big concern with earlier versions of hormonal contraception in women, especially in female smokers, is the elevated rate of blood clots. And this is blood clots in the veins, so deep venous thromboses or pulmonary embolism, which is a very different form of vascular disease and not related to calcification. So different form of vascular disease. I think, I am encouraged to see Pam's experience in South Africa. I mean, that sounds like you got great vascular care in this, by a thoughtful vascular surgeon who tried to, treat this with a stent. And then when that didn't work, did a bypass. And I think absolutely being on aspirins and statins in the setting of a bypass, we know are extremely important. And like you said, hopefully you will never need to know if shockwave therapy is a good therapy for this, because your bypass will just continue to work and you'll do great. Reed is asking if there's urgent vascular risks due to PXE or the risks are more progressive over time. I haven't seen anything suggesting there's a higher rate of acute limb ischemia. And so acute limb ischemia is you're fine. And all of a sudden you have horrible pain in your leg. And if we don't get you more blood flow to your leg, you're going to lose your leg. That is usually due to embolic disease or blood clots from your heart breaking off and going to the legs. or is sometimes due to narrowings in the legs where they get so narrow, so narrow, so narrow, and then they clot off and the blood stops flowing and they present acutely. The type of vascular disease we see in PXE really tends to happen much more slowly over time, and I don't think lends itself to really an increased rate of acute limb ischemia. Is pain in the Achilles, elbows? There was an arm strength question that I feel like disappeared somewhere. So someone had asked about whether or not decreased arm strength could be a sign of this. I think it's hard to say. Decreased arm strength could be a sign of a lot. There certainly is atypical forms of peripheral artery disease symptoms in the legs that present primarily as patients saying, I can walk only so far, and then my legs get weak and I have to stop and rest. And then I can walk again with normal strength. So I don't think of like overall lack of limb strength as a vascular phenomenon. And even when people explain to me of having kind of exercise limited strength, I always make sure we don't have an underlying nerve problem. But we can see there are upper extremity equivalents of lower extremity claudication. So if you think about, for example, different activities you do with your hands, it's common to see people say, I can't do work above my head because my hands start hurting. I tried to paint a room in my house, and 5 minutes into painting, both my hands or one of my hands really started hurting. Women who have long hair, who have upper extremity vascular disease, will actually come in and say, it's really hard to comb all of my hair now because my hand starts cramping up. And so there are upper extremity equivalents to this. Again, upper extremity disease in the general population is much, much more rare. So is pain in the Achilles, elbows at rest vascular? I think that generally we think of rest pain while claudication occurs in the parts of the limb that are metabolically active, so where the muscles are, rest pain tends to occur in the things farthest away from the heart. And so when people come to me, and this is true, this is true whether it's PXE or regular artery disease, people come to me and say, my calves hurt when I sleep, or my legs are really crampy when I sleep. That's not usually vascular. The rest pain we see in vascular disease is my feet and my toes. And when I have to dangle them over the bed in order to feel better. And then I dangle them over the bed and they feel better. And that's because the gravity helps the blood get down there. Looks like Gretchen S. recently had a carotid artery study, 30% on one side, 40 on the other. Is there a way to know if that's calcium or cholesterol, or does it matter? It doesn't matter, and it's probably both. And I would tell you that in cerebrovascular disease, so blockages in the arteries that go to the brain, and the carotid in particular, in many, many, many individuals, and probably in more than 50%, that is usually calcified plaque. And so there really is no way to tell, because the normal presentation of that is calcified plaque in your arteries. It almost certainly does not matter. I think really the question is, keeping an eye on that, doing everything you can do to prevent developing, modify your risk factors so you don't risk having further atherosclerotic disease, and then trying to, follow that closely. Ultimately, does that get to a point where something needs to be done procedurally or not? The good news is that most, I don't know how old you are, Gretchen, but most people who have that type of or level of narrowing tend not to progress over time. We do tend to follow it, yearly or every other year with an ultrasound, but the rate of progression is not very high. So someone was asking about arthritis. Carrie is asking about arthritis and intermittent claudication. There isn't, as far as I'm aware of, a link between intermittent claudication and arthritis. We think of arthritis primarily as a disease of the bone and the joints and the cartilage in the joints. and vascular diseases superimposed on that. Where they start to get conflated is in people who have both, and we're really trying to figure out, well, actually the real trick is, unfortunately, Carrie, where it gets confusing is when people come in with pain in their feet and we're trying to sort out if it's gout, if it's vascular disease, or if it's arthritis. Because obviously, as you know, the treatment of all three of those is very, very different. We don't think of them as being related, but they actually co-occur in a lot of people.
Okay, anything else? Okay, Scott, this was fabulous. I think the bottom line is exercise, which we talked about earlier today and actually yesterday too, that it increases pyrophosphate levels and would be a good first defense against many, many things, including normal heart disease and normal peripheral artery disease. And the second message might be that unfortunately, guys, you can have more than one disease. And one of the things that we kind of struggle with in answering things for lots of you is that many clinicians and many people want to blame everything on PXE, and that's not really a good idea because there may be treatments for other things that you have, like familial heart disease or claudication that's caused by something else, or you smoke and maybe you should stop smoking and so forth. So we really encourage you to kind of look at your whole self, not as a walking PXE, but as a complex individual. And then the third one would be, sorry, go ahead, Scott.
Oh, no, I think I was probably, I didn't realize you had a third one. I had a third one, but why don't you give your third one? Because I suspect it's the same. I suspect it's the same thing as your third one.
Go for it then.
I was going to say the third one in my mind is that there's a lot we don't know about vascular disease and PXE, and a lot that we could very, very easily answer with registry questionnaire data. And at the scale that the registry is now, if everyone wrote in and filled out questions on this, we'd have some pretty definitive answers about the rates and the durability of these interventions and really be able to understand what the best way to approach and treat, at least from my standpoint, the vascular complications of this disease are.
Yep.
Did I guess your third one, Sharon?
You got it perfectly. Yes, thank you. In fact, we waived the registration fee, which was only $25, to everyone who filled out any of the questionnaires. So we I hope got a good number of you filling out the questionnaires, and we will be bugging you in the weeks to come. Super. All right. Thanks so much, Scott, for that presentation.